My vision is that the patient can have, when they have their regular eye scans with their optometrist every year, that particular eye scan can be coupled with an AI model that is really fast and very well validated and accurate. And those well validated algorithms can generate a very clear and individualized risk profile for both cerebrovascular disease as well as neurodegeneration.
A lot of people think of Alzheimer's disease as something that becomes visible only when the memory starts to slip. But by the time symptoms appear, the disease may have been unfolding quietly for years, even decades. Now imagine this. One of the most revealing clues about the brain may be hiding in plain sight, in the back of the eye. The retina is the only part of the central nervous system that can be seen directly and non-invasively. That gives researchers a remarkable opportunity to look for patterns linked to Alzheimer's disease in a way that feels almost magical, but grounded in real science. Teams at Mayo Clinic and beyond are studying whether artificial intelligence can detect retinal patterns linked to Alzheimer's risk long before symptoms appear. That's what we're talking about on this episode of Tomorrow's Cure from Mayo Clinic, a podcast that brings the future of medicine to the present. I'm Lindsey Seavert. It's great to have you with us. Joining me today are Dr. Oana Dumitrascu, a neurologist at Mayo Clinic, and Dr. Yalin Wang, a research faculty member in the School of Computing and Augmented Intelligence at Arizona State University. Today, we're really talking about the possibility of finding Alzheimer's disease earlier with a routine eye image and AI, artificial intelligence. But before we get into all that technology, I first want to zoom out and understand when it comes to Alzheimer's, why early detection matters so much. And according to the latest information from Mayo Clinic, nearly 7 million Americans are living with Alzheimer's disease today. That number is expected to double in the coming decades as our population ages. And more than 70% of those individuals with Alzheimer's are age 75 and older. Mayo Clinic researchers found measurable Alzheimer's-related biological and cognitive changes begin with a lot of people in the late 50s, decades before these symptoms appear, which really brings us to this conversation about early detection. So, Dr. Dumitrascu, I'd love to ask you, when you talk to patients and families about Alzheimer's disease, what makes early detection so important?
As you pointed out, Alzheimer's disease poses a significant public health concern and is a national research priority. And this research priority stems from the fact that this disease is currently often diagnosed too late when the symptoms become apparent. And therapies are not applicable in late stages, as they were shown in multiple studies to not be effective. Additionally, Alzheimer's disease may coexist with cerebrovascular disease, and the presence of concomitant cerebrovascular disease often exclude the patients from currently existing Alzheimer's disease targeting therapies. So there is significant evidence that supports that Alzheimer's targeting interventions are the most effective in the Alzheimer's disease preclinical stage, something that we call pre-symptomatic stage, when individuals have normal cognition, they have no concerns in their activities of daily living, either basic or instrumental activities of daily living. However, they do have evidence of deposition of abnormal proteins in the brain, and there is evidence of neurodegeneration already, despite them having no symptoms.
What are the general protocols today of how do we detect and diagnose Alzheimer's disease?
The general protocols are when patients present either to their primary care providers or to neurologists in specialized cases with cognitive concerns. So at that time point, the standard of care is cognitive testing, usually a screening type of test in the primary care provider's office, or a more detailed neuropsychometric testing that takes a couple of hours. That is usually done by a psychologist. In addition to that, there are some laboratory testing that are being conducted and usually a brain MRI. This is pretty standard. Most recently, we have emerging blood-based biomarkers that are showing evidence of significant promise to diagnose Alzheimer's disease in early stages, probably not yet in preclinical stages. They are not yet ready for prime time. Once a patient is being diagnosed with possible Alzheimer's disease, then that's when they are usually referred to a tertiary care center or to cognitive neurologists. And that's when more specialized testing is being conducted, such as lumbar puncture and the analysis of the cerebrospinal fluid for those abnormal proteins that deposit in the brain, or a specialized type of PET type of imaging called amyloid PET.
Yeah, I think that's where a lot of us, living our lives or within our families first encounter those symptoms of Alzheimer's disease within a family member or relative. For me personally, right now, I'm caregiving for an aunt with Alzheimer's disease. And it first came from a call from her doctor saying they had concerns. And we followed up with a neuropsychological exam. It went from there. And we realized that it probably started to accelerate during the pandemic when there weren't a lot of interactions with people and we weren't able to visit her a lot. And we did realize that, yes, this has probably been happening for years. Dr. Wang, you come in with sort of this new frontier to detect Alzheimer's disease, and that is with the eye. I would love to hear more about that.
I started this research by following Dr. Dumitrascu's work. They discovered that the eye has the early symptom, and we can find the features which correlated to neurodegeneration, such as Alzheimer's disease. And what we do in our lab is we try to develop and apply the AI technique so that we can achieve the scalability so that we could identify Alzheimer's disease in an early stage in a more inexpensive and scalable way in the primary eye clinics, for example.
So you said that your jumping off point was you're following Dr. Dumitrascu's work.
Yes.
What really intrigued you, or how are you collaborating with Dr. Dumitrascu?
Our past work, we focused on the structural brain MR and also, for example, the PET. I'm inspired by the vision of Dr. Dumitrascu proposed, seeing the brain through the eyes. Essentially, eye is part of the brain. So basically, it shares all the features of the brain, but distinctively from other parts, this part of the brain is not covered by the skull. So it's some part of the brain we could directly visualize. We can directly image. And so that the eye imaging technique was used in diabetes retinopathy and also glaucoma already. So basically, we find that this is also a very intriguing new direction based on Dr. Dumitrascu's work, so that we could use imaging technique for early Alzheimer's disease discovery, the identification.
So, Dr. Dumitrascu, take me back to the work that Dr. Wang is speaking of. Where was this shifting point for you when you had your tools for diagnosing Alzheimer's disease and then entered the eye, or the images that you can see through the eye?
I've been researching retinal imaging as a window to brain health for almost a decade now. We all know that the eye is an extension of the brain, and it's actually the only part of the body that we can quickly and non-invasively visualize the health of the brain and the health of the vascular system. The back of the eye, called retina, is the only place where we can actually quantify the vascular health, and those vascular parameters in the back of the eye correlate with the brain vascular health as well as with the systemic vascular health. Furthermore, we have shown that using specific analysis of the retinal vasculature, we can be effectively distinguish patients with pre-symptomatic Alzheimer's from controls, perhaps because those abnormal proteins that deposit in the brain and retina are affecting the health of the vasculature as well. In my prior work, I was able to demonstrate that the retina can accumulate the same type of proteins, tau and amyloid, that the brain of an Alzheimer's disease patient accumulate. But the advantage of the retina is that those proteins can be visualized non-invasively, repeatedly, without any radiation. However, The easiest type of retinal imaging that is currently available widely is retinal fundus photography. So using fundus photography, that is a very cost-effective technique of visualizing the back of the eye, we can't really quantify those abnormal proteins that deposit in Alzheimer's disease. So that's when the advantage of artificial intelligence come into play. Artificial intelligence assisted analysis of fundus photos was shown to be able to distinguish patients with Alzheimer's disease from patients with normal condition in a few studies, including ours. So now we're taking this to the next level, researching the accuracy of an AI assisted tool in pre-symptomatic Alzheimer's. So we're trying to screen for patients with pre-symptomatic Alzheimer's, not only in our academic center, but also in a demographically diverse population in rural Arizona.
In general, people tend to have more regular eye exams, which gives this pool of data. And Dr. Wang, that's where you come in. Can you enlighten us of how AI sort of overlays with the images of the retina?
So my understanding is that the imaging, for example, color founder photograph is very easy to obtain, inexpensive, non-invasive. But the challenge with regarding our work is that the Alzheimer-related retina change actually can be relatively subtle. For example, the not that obvious as diabetic retinopathy. So that's why we rely on AI. AI allow us to analyze this kind of the millions of tiny image features simultaneously. The feature include a vascular branching pattern, vessel tortuosity, and all those kind of spatial organizations of the vessel structure. So if we do it, manually, unrealistic to quantify. Another exciting aspect of our work is that we also use AI, the generative model. For example, the one we use in ChatGPT, Gemini. We use similar technique, generative model, which could rescue the lower quality retinal image collected in the real world setting, especially, for example, in the rural or the mobile clinics, such like in Arizona. We help recover the features otherwise will be discarded.
So, did you have to develop your own AI platform specifically to analyze these images?
Yes, we develop our own system, and one as for example the generative AI, and also in this system we have lots of different components. We have actually several patterns, and also we have different framework, and then more importantly, we develop a comprehensive way to evaluate the system, including expert rating, including the ground truth data, the voxel-wise comparison, or also the downstream applications. And the others, for example, the Alzheimer identification, we also utilize our own tools to analyze the image to get the conclusion.
How much of a game changer was this when you're uploading all these images into the AI platform that you created and all this data is coming back? What kind of wow aha moment was this?
So basically, the team in Arizona, so the mobile lab, they drive a van and driving along on the Arizona rural area to collect all different data, including the retina images. So in their device, they have a green light indicating the quality. They find that even with the green light, 42% of image actually were not usable. With our AI tools, we can roughly rescue 57.7% of such image. We turned them into usable images.
57% compared to 42%?
So among this 42%, we converted 57.7 from the unusable to usable.
That translates to early detection for more people.
Yes, and a more reliable featured identification. So, and at least it receives the time and all the resource to collect such data.
Dr. Dumitrascu, could you tell us a little bit more about this mobile lab in rural Arizona where you're collecting a lot of this data and gaining a lot of these retinal images?
This work is done in collaboration with one of our academic institutions that have a mobile laboratory in a van, in fact, in which they collect blood low field brain MRI. They perform cognitive testing, as we discussed. This is the screening. They also perform genetic testing using a very simple methodology. Very recently, they became interested in our very cost effective and simple and non invasive retinal imaging. So they adopted this retinal imaging using a portable scanner. It had a very fast learning scale for the entire research team, and patients provided informed consent to have their retinal imaging taken. We are utilizing their retinal images to provide a quantification of their vascular health, as well as to correlate the retinal imaging findings with more established biomarkers of early neurodegeneration.
So a lot of things are sticking out to me as just low barriers. You said it's a very simple tool, early detection. Not everyone might have access to leading to a primary care doctor and having a neuropsychological exam. What are the benefits to that process that you described, specifically than AI being the best one of all?
Yeah, so my vision is that the patient can have, when they have their regular eye scans with their optometrist every year, that particular eye scan can be coupled with an AI model that is really fast and very well validated and accurate. And those well validated algorithms can generate a very clear and individualized risk profile for both cerebrovascular disease as well as neurodegeneration. And that will help in two ways. It will help with guiding counseling, prevention, and when appropriate, early treatment, as well as screening patients for clinical trials. We really need to find better ways to conduct clinical trials in neurodegeneration to identify those patients early, as well as to have a very accurate modality to monitor them during those particular treatments that are being studied. This ideal scenario, patient could have this type of scan in a familiar setting, and the results are standardized, reliable, and connected to the appropriate follow-up care.
Dr. Wang, can you describe a little bit more of your work in this field when it comes to the retina revealing a lot about brain health? Why is the retina the optimum viewpoint for brain health, and what are you seeing?
So I'm the computer scientist. So basically, we are doing the imaging analysis. My interest was in the imaging research for neurodegeneration disease. So when Dr. Dumitrascu introduced this topic to us, I was very excited because we see the potential, we see the scalability, we see the affordability to have this kind of the data collected. We find that AI give lots of benefit to analyze such image. We could analyze them using today's technique. We could analyze them very fast way. And also we developed several different technique. For example, the unsupervised learning technique, so that we could achieve the zero shot or few shot approach to analyze the image. The Alzheimer research using retina image are still a very challenging. AI research, no matter the generative AI or those kind of different foundation models, and even the vision language models provide lots of tools for us to achieve our goal for the early detection of Alzheimer's disease.
And Dr. Dumitrascu, you said you've been researching the retina's relationship to observing Alzheimer's in the brain for over a decade. Do you remember the point when artificial intelligence came into the picture and you realized this could be a tool?
Yeah, absolutely. So when FDA approved the first AI-based algorithm for disease screening, which is retinal imaging coupled with AI to screen for diabetic retinopathy. So that was the first FDA approval, and we wanted to follow this and prove that AI-assisted retinal imaging can screen for neurodegenerative disorders. Second was when I was trying to identify these abnormal proteins in the retina. And that proved to be a very complicated retinal imaging system for the patients. And I realized that this may not be scalable anytime soon.
Were you skeptical at some point?
I was skeptical about the scalability of this type of approach. Our first AI study was using both Mayo Clinic population as well as a large European population of patients with Alzheimer's disease and normal controls that had fundus photos. And with the help of Dr. Wang and his team, we are able to see that an AI applied model can very accurately distinguish patients with Alzheimer's disease from normal controls. That gave us a lot of confidence. The next challenge that we took on was translating this into a preclinical Alzheimer's disease population.
If you have a scan of someone that has the early signs of Alzheimer's, you could not read that with your naked eye. You need AI to give you those clues up close. Is that right?
Currently, there are no validated specific retinal vascular biomarkers for Alzheimer's disease on fundus photography.
Dr. Wang, then what does AI do? What does that look like as you put these images into your platform, your AI platform? What is revealed?
Our tools, we have some of the computer models. We could train the model, neural networks, we call it the different mobile net. And so that by providing annotated image, some image from Alzheimer's disease patients and some image from the cognitively unimpaired persons, so that our neural networks, together with our unsupervised learning technique and the different technique, put them together, we could achieve the identification of Alzheimer's disease patients or for example, even early stage. These are the purely technical approach. But eventually, we would follow the medical doctor like Dumitrascu give us the final say to check whether the results are reasonable, biologically founded.
Dr. Wang's team was telling me using this AI model, we have 90+% accuracy in classifying and distinguishing fundus photograph deriving from a patient with Alzheimer's with a normal control. So my next question was, can you tell me what is telling the AI model that this photo is from a patient with Alzheimer's disease and not from a patient that has normal cognition? So a lot of work in the past 4 years was done trying to understand what's the underlying biomarkers that is particularly specific for Alzheimer's disease, because neurodegeneration tends to be really complex. So we thought that we learned that medium-sized blood vessels and small-sized blood vessels in the back of the eye and those surrounding areas are the underlying biomarkers for Alzheimer's disease. We're still trying to understand what is particularly telling the AI model in pre-symptomatic Alzheimer's disease, which tends to be even more challenging than Alzheimer's disease itself.
And just to pull that out a little bit more, what are the underlying biomarkers that you're looking for?
Underlying biomarkers of Alzheimer's disease in the retina are amyloid and tau and inflammation and vascular dysfunction, but you cannot simply visualize them on a fundus photograph, other than the vascular dysfunction, which may not be necessarily particularly specific for Alzheimer's disease. So we are trying to ask the AI model if what is the underlying biomarker as well. And of course, the next step is to rigorously validating this against specific Alzheimer's disease biomarkers such as amyloid PET, cerebrospinal fluid analysis, and most recently, blood-based biomarkers.
So you essentially have to compare this new process with the retinal images and AI to these standard ways that you would diagnose Alzheimer's through the amyloid PET imaging, the blood-based tests, right?
Absolutely. That's our current challenge.
Dr. Wang, I imagine if a patient hears that a doctor is going to take an image of the retina and put it into AI, you might have some raised eyebrows. How do you really know if AI is correct here and reliable? It's still a scary wilderness for a lot of people when you mention AI. So I ask you, Dr. Wang, how do we make sure that AI is reliable and not misleading?
We need careful validation. For example, we need large multi-center studies and also diverse populations and also the different environment, the data, and to be validated with other biomarkers.
which is where a clinical trial would come in.
Yes, that's what we need to do next.
Dr. Dumitrascu, how do you speak to patients who might have some very well-founded qualms about AI analyzing their retina? How do you believe that AI will be reliable in analyzing the retina for signs of Alzheimer's disease?
Well, what I tell my patients currently when I enroll them in our research studies is that we need to learn more. A part of AI that I am most interested in is explainable AI. So really understanding that particular underlying biomarker that is telling the AI model that a disease process may be going on. And I tell my patients that this is the first step for us to try to build a model that may work. Second is to validate it against existing biomarker, and third, to deploy it in a large scale once it's well validated.
Dr. Wang, what do you see as a computer scientist yourself, the scientist's role in exploring Alzheimer's disease detection through the retina?
To me, it's a very exciting direction and also a very useful direction. We have seen that the fast advancement of AI technique and in everywhere. If we could use any data collected from the clinics, the not necessary to be very complicated device, and we could have strong confidence at least to do the screening. I think that this is really the very exciting direction. And also, this line of research provided me and my students the real problem, the real world research problem, so that we could directly see the impact of our research and about our technical development.
If this becomes part of routine practice, could really shape or reshape who gets screened, when they get screened, and how the healthcare system thinks about brain health and prevention. What's the next challenge? How do you keep exploring this in order to pursue this as part of practice?
Our vision is that eventually we want an AI system with different input together with our knowledge we learn from the past literature of even from the electrical health record, so that the AI system could become an assistant to the physician like Dr. Stroke, provide this assistant for the doctors to make diagnosis or the prognosis. I think that's the vision and that's the goal we are trying to achieve.
Dr. Dumitrascu, what do you think about what Dr. Wang is saying about creating a more robust system that's available to physicians like you?
Yeah, absolutely. That's why we're doing this work. So we empower providers, and our next project is to utilize the electronic health record, as Dr. Wang said, the robustness of an electronic health record, and to perhaps create a model that can accurately predict the risk of neurodegeneration just using electronic health record when available. I think the most important challenge that we're having currently is differentiating Alzheimer's disease from mixed dementias, mixed pathology, mixed cerebrovascular, and neurodegeneration, particularly monitoring these patients with mixed pathologies carefully in Alzheimer's disease targeting clinical trials. It was shown in prior clinical trials that Alzheimer's disease targeting therapies may actually worsen the cerebrovascular disease. So we would like to understand this relationship better, utilizing the advantage of AI.
Yeah, I know that's often the case. The aunt that I mentioned, my mother's sister, who we're caring for, has a mixed diagnosis of Alzheimer's and vascular dementia. And so you're talking about some of these coexisting types of dementia or conditions. Do you think that we will also get to a point where you can diagnose other neurological conditions through the retina too?
There is work that we've done, but very limited, in Parkinson's disease as well, which is another neurodegenerative disorder in which another protein is depositing in the brain. It's in the synucleinopathy type of disorders. And there is significant work showing that maybe the eye is the window to the brain in Parkinson's disease as well. And interestingly enough, a retinal vasculature is also affected in Parkinson's disease as well, just like in Alzheimer's disease, just like in cerebrovascular disease. That's why we need more rigorous studies to really understand what's that particular vascular biomarker in each of these disorder.
I'm just wondering about people out there listening who might have a family like mine. There's Alzheimer's in the family. What should we know as patients, or what kinds of questions should we be asking with our own providers?
Taking care of a family member with Alzheimer's disease can be difficult. It could increase probably our level of anxiety that this could happen to me one day. So, being proactive and talking to your primary care provider about brain health and what you can do to preserve your brain health long term is extremely important. Then, considering enrolling into pre-symptomatic Alzheimer's disease clinical trials. There are clinical trials that are just monitoring patients and trying to develop existing biomarkers, such as ours, or there are therapeutic clinical trials at different stage of the disease on the big continuum of Alzheimer's disease, starting from normal cognition all the way to probably mild or moderate dementia. So, trying to understand what you can do before the symptoms develop. Some patients may want to know what's their genetic risk, and that's something to be discussed with the provider as well as trying to understand what's the role of less invasive testing, such as blood based biomarkers. When should you have this type of testing? When should you have a cognitive testing done? These are very good questions to be addressed with the primary care provider.
Are you hopeful that someday in your lifetime doing this work that this test, this retinal imaging using AI will be routine for patients just as part of your regular eye exam?
Absolutely. This is my vision, but we do have a lot of work to validate the accuracy.
And then Dr. Wang, I mean, every day AI is developing at lightning speed, far beyond what we can even grasp our minds around. So as AI continues to advance, how does that advance the way that AI reads the retinal images?
The AI technique developed very fast. We have the new ideas very quickly to address the problem we couldn't solve in the past. The more results will come along. Currently, we view the AI development has three pillars. One is the model, the other one is the computational power, the third one is data. We think that the next big opportunity is the data. So that's our group, and we work with Dr. Dumitrascu. We try to study the problem we are trying to study. So we try to have more data and more high quality data and more annotated data so that we could fit them in our system, and so that makes our system smarter and improve its accuracy. For example, in our recent work, we use different public resource. For example, the PubMed, the public library from NIH, or even the YouTube. We go there to collect the data, and then using the current vision language model, such as ChatGPT, Gemini, or our own vision language models, we could do better annotation and then to enrich our data. Based on that, we also do the data synthesis so that we could have larger amount of data which cannot be imaginable in the past. And with this kind of the development, with this kind of accumulated data, we think our system will be more practical and will be more adaptive, will robust to different population, different aging people, and then solve all the current difficult problems.
And Dr. Dumitrascu, data that Dr. Wang speaks of, data drives change.
Absolutely. And we need hundreds and thousands of individuals with preclinical Alzheimer's in order to validate this. And preclinical Alzheimer's is not very well characterized in the general population. I'm hopeful that with the emerging blood based biomarkers, this is going to be easier, but currently it is challenging. That's why we are shifting towards using the advantage of electronic health record and agentic AI to move forward with this type of research.
There's so many shifts at the cusp of what we're discussing today. Not only is it that you can see the brain through the eye, you can see the retinal changes that could be include Alzheimer's. You overlay it with AI, another big aha. The other shift is that earlier diagnosis, earlier detection, which really changes everything instead of just realizing that you have Alzheimer's at the dawn of your memory loss, right? So I'm just curious about what you both think about how this shifts sort of the emotional journey of Alzheimer's and the way that we live our lives.
Absolutely. That's why I think we need to be very careful. I think the most important application of this will be not necessarily to screen for preclinical Alzheimer's and telling them that maybe in 2 decades from now they will develop Alzheimer's disease, but most importantly, to enroll them in preventive clinical trials and to monitor them during these clinical trials with a well-validated monitoring test that will show an effective response to therapies. That's what we currently have lacking in the field. Unless we're going to have an excellent preventive regimen, we will have an emotional response to the notion that we may have pre-symptomatic Alzheimer's disease, because currently there is no treatment. However, preventive medicine and preventive vascular health is a field that is emerging and developing as we speak, and that is mainly consisting of multi-targeted lifestyle interventions that we know to be effective, even in patients at high genetic risk for Alzheimer's disease. So I do see the benefit, even if it's only multifaceted lifestyle intervention.
So while we don't have a cure at this moment, what you're kind of telling us is that there's still a lot we can do and there's still a lot of hope on the horizon.
Absolutely.
Yeah, Dr. Dumitrascu, you talked a lot about needing data to launch a clinical trial to drive change. I mean, how long is this horizon or the timeline to get all this data?
Yeah, this is a moving target because it all depends on how powerful the computational analysis as well. When we first started AI studies, even 5 years ago, we needed million of patients in order to develop an accurate tool. Nowadays, things are changing, moving from unsupervised to self-supervised models was able to decrease the sample size significantly. So the short answer is I cannot give you a timeline, but I'm optimistic that Dr. Wang and his team will be able to develop accurate models with more limited sample size. What is very important, though, is to validate this in demographically diverse populations with various ethnicities, as well as genders and populations across the nation to begin with, and globe in a secondary stage.
Dr. Wang, what is the role of AI as an assistant here in this situation, and what are the next steps towards getting there?
This line of research, the multi-center clinical trial, would very important. It is a fair standard for us to test, evaluate the technology. And so basically everything I try to talk about here is from the technical development point of view. So we really want to have the data, and then we have the feeding our system using the current infrastructure to advance our technology deployment. That's the next step. We in the clinical trial we should have better understanding to the available technique. For example, the biomarkers, how robust our system could develop the biomarkers, and how useful those biomarkers are. And eventually, from my vision or point of view, so basically the data to advance the current AI system, so that to help to provide this AI assistant for the medical doctor for the diagnosis and prognosis. I think the current bottleneck is the data. That's why we spend so much time to collect data from the public domain or from the electronic health record. So basically all those kind of resource, we try to improve, collect the data so that we could move our AI system to the next level. The clinical trial will be the standard, will be the test bed to validate our systems, our technology.
Before, when you had these images of the retina, and now when you have these images of the retina reviewed by AI, why could you not collect as much data before AI was a tool?
If we define AI as this complicated machine learning algorithm, before we use them, for example, the medical doctor as Dumitrascu already use other methods, statistical method, so that to do the different feature analysis, regression model, or different statistical method to identify the biomarker. What the AI help most is that the AI could do this very quickly and scalable, so that analyze them very quickly, very accurate. I think that's what AI help us. The biomarkers still from the medical doctor's vision, from medical doctor's practice, from their experience, but AI kind of the automatic method to do it quickly and then more comprehensively.
So that's where the scalability comes in. AI can just do it faster in larger quantities.
That's what I think. Medical researcher, medical doctor already work on these images, and they use different ways to extract different biomarker feature, and study them. Just try to do another level to be the faster, to be more accurate, and then the automatically.
So, quantification of vascular biomarkers in the back of the eye was extremely tedious when I first started to do this type of research. And it's currently still not existing in routine clinical practice. Semi automated pipelines to quantify the retinal vasculature or even retinal amyloid deposits have been developed over the years. However, they were not successfully translated into clinical practice as they required a lot of human help. So the first challenge that we took on together is to generate point of care applicable biomarkers for brain health. We have one of our research outputs is an automated retinal vascular health biomarker that now we are studying the correlation with neurodegeneration as well as brain vascular health. So this is the AI assistance that can be provided to the physician, just the generation of an automated retinal vascular health biomarker that can be currently performed in seconds using an automated method.
If you did this yourself, you mentioned it was tedious. This would take you a really long time. Like, what is it like to look at the image without AI with your own eyes?
So the image itself shows us the vasculature. It does not provide an automated biomarker of how complex the retinal vasculature is. Prior semi-automated methods or even deep learning methods that were published still require a lot of computational expertise. So still not available to each of the providers, each of the physicians, optometrists, ophthalmologists, primary care providers within seconds. What we have developed is something that will take this automated biomarker that is the output of the AI model to the next down the stream decision making processes.
So what I learned from Dr. Dumitrascu was that the medical doctor can explain the structural change by the blood flow, by the degeneration process. By the observing, measuring the vascular structure, they can tell whether it's normal or abnormal. Recently, the project we do is that we use AI to enhance the image, to try to identify this feature more accurately, fast, and so that we could provide the medical doctor this kind of feature quickly. And so still we depend on Dr. Dumitrascu's the experience or the vision to check whether this is a correct observation or it's just false positive.
Yeah, so the doctor is still making all the clinical observation and the diagnoses. Is just more data. Sounds right for a clinical trial, as you mentioned.
Right, this is just an assistive tool for providers that will need to be validated against existing biomarkers that are well recognized.
As you know, this podcast is called Tomorrow's Cure. And unfortunately, today, no treatment can stop, reverse, or cure Alzheimer's. But I'm just wondering for the both of you, what gives you real hope about progress and the sense of wonder with this treatment and where we're at now? And Dr. Wang, I'll start with you.
I have a high confidence to find the drug so that could prevent the Alzheimer development in its early stage. In the past several years, we already see several FDA-approved medicine for the Alzheimer disease prevention and treatment. Personally, I'm very promising for the industry to discover this kind of drugs so that could prevent the Alzheimer. And also our research actually also help with the biomarker we discover actually could reduce the cost to speed up the drug development process. I am very optimistic.
You're optimistic that the research now can accelerate drug development?
Yes. I also think that it's promising to have new drugs available to the patients.
Dr. Dumitrascu, what is giving you hope about progress right now in this field?
The hope is coming from understanding how complex things are and the fact that we need multifaceted strategies. I think we need medications to target neurodegenerative process. We need better medications to target vascular dysfunction, and then we need lifestyle interventions. Every day, we're learning more about the complexity of neurodegenerative disorder, the importance of the associated vascular dysfunction in the brain, as well as the importance of preventive medicine to maintain brain health for more decades.
I really appreciate you both. The Alzheimer's journey is just gutting and brutal for so many Americans living this reality, and the fact that this is in development and that you both are working on this with such brilliance is really gratifying and gives people like me and so many out there a lot of hope. So we just really appreciate it and wish you the best of luck.
Thank you for having us.
Thank you.
Tomorrow's Cure is a production of Mayo Clinic with production help from The Podglomerate. Be sure to follow Tomorrow's Cure wherever you get your podcasts. And if you liked today's episode, please like and subscribe. I'm Lindsey Seavert. Thank you so much for being with us.